This is Connor Meadows going over the stable ventricular tachycardia paramedic algorithm. If you have a patient that you have come in contact with, that you have determined their airway, breathing, and circulation, and you have hooked them up to the monitor and recognize that they are in a tachycardic rhythm with a pulse, the algorithm goes as follows. You will assess and support their ABCs as needed. You'll give them oxygen if they're hypoxic and monitor their EKG, their ECG, their blood pressure, and their pulse oximetry for the duration of your patient contact. You will identify and treat the reversible causes of the rhythms. If the patient is stable, meaning that they do not have chest pain, altered mental status, hypotension, then they are considered stable. If the patient is stable with ventricular tachycardia, you will establish IV access, obtain a 12 lead, which you've determined to be stable Vtach, and if the QRS is narrow, less than 0.12 seconds, then if your patient is stable and they have a QRS complex that's smaller than 0.12, then they are in a narrow Vtach. Narrow Vtach can either be regular or irregular. If it's regular, you will attempt vagal maneuvers and give adenosine 6 milligrams rapid IV push. If they do not convert out of the Vtach, you will give them a second dose of 12 milligrams rapid IV push. You can repeat the 12 milligram dose one time. Depending on whether or not they convert out of the tachycardia at that point after the adenosine. If they convert, then the patient will probably re-enter SVT. You will treat the recurrence with adenosine until you max the adenosine dose out. If they do not convert with the adenosine, then the patient will probably go into atrial flutter, ectopic atrial tachycardia, or junctional tachycardia, at which point you will try to control the rate using beta blockers, dilazolam, but ultimately you'll just be trying to treat the underlying cause, considering the H's and T's, and you'll consider your expert consultation. Going back, if the patient is in stable Vtach with a narrow QRS and it is irregular, it's an irregular narrow complex tachycardia, the patient is probably going to be in atrial fibrillation or possible atrial flutter, or multifocal atrial tachycardia. And at that point, you will consider expert consultation, and you will again try to control their rate with beta blockers, if the patient has a wide supraventricular tachycardia and it is regular, so if it is a wide, regular, stable Vtach, you will treat the patient with amiodarone, 150 milligrams IV push over 10 minutes. It's a bolus. It's a 150 milligram IV bolus over 10 minutes as needed to maximize to a maximum dose of 2.2 grams within 24 hours. Obviously, you will drop the patient off, hopefully, by that point. You will also, if the patient is in a wide, regular, you do need to be prepared for elective synchronized cardioversion, depending on what the consultation of the doctor would be along with the patient, if the patient is stable and wants to make that decision. If the patient is in SVT with aberrancy, you will give adenosine and you'll revert back to previously. So ultimately, what it really comes down to is the H's and T's and determining if the patient is in narrow or wide stable Vtach. And again, your main doses and drugs are going to be your adenosine, 6 milligrams and 12 milligrams, rapid IV push. And on the wide regular spectrum, you're going to be looking at your amiodarone, 150 milligram bolus. And that is the treatment for stable Vtach for paramedic protocol.